Am I still mic'd? Are we mic'd outside? I don't think this will help. Well, I don't think anybody outside can hear me. If anybody has their friends who are out there milling around, chatting, we need people to start drifting back in so that we can begin again. I have a sister who was an elementary school principal, and she said what you do is you just start talking and keep talking, and then eventually people start paying attention. I don't know if this is true, but I'd like to ask people to start drifting back in. I know that one of the really important parts of a meeting like this are the conversations that you have outside of the meeting room, but I want you to have a full hour for lunch and not have to cut it because we've run too far behind schedule. Are you mic'd? Or are you going to speak here? You're going to speak from here?
Yeah.
Perfect.
Why?
I'm going to introduce you.
Yes.
But first people have to, you can stand, it's fine. And now I'm giving up on my written remarks. All right, I want to urge everybody lurking in the doorways to please make your way back in as we move on to the next session of this morning. It's really my hope that there will be time for our scheduled full hour for lunch. So we've had so far a very U.S.-centric conversation, and I'm really thrilled that we have with us today somebody who's going to bring something of an international perspective to the conversation that we're having here. I believe one of the speakers showed a slide from France, and I'm very pleased now to be able to introduce to you Dr. Patrick Aeberhard. He is the vice president of the board of FXB France. That's my effort. He also serves as part of the on and off as part of the advisory committee for the Center for Health and Human Rights at Harvard University. He has a history that you can read in the program book, involved in the establishment of MSF, of Médecins du Monde, and he has come all the way from Paris to speak with us. It's my pleasure to invite you, Dr. Aeberhard, to say some few words.
Thank you very much, Mary. It's a pleasure to be here. I'd like to thank the Center for Health and Human Rights to have invited me. Thank Mary Bassett, Dean Williams. Hello, how are you? When I arrived and thinking of the figures of the opioid crisis, I wasn't very well. But after listening to the different people intervening this morning, I'm much more positive. I think we are on the same level of thinking, and it's true in France, the number of opioid deaths is much lower, but the situation is also very difficult for drug users, and stigma is still in the center of the problem. I'd like to pay a tribute to Dr. Jonathan Mann. He was my mentor. He was the first director of the Center for Health and Human Rights, and he was the director of AIDS at WHO, and he was an incredible personality.
Les modèles sont les suivants. Le modèle 1, c'est le modèle qu'on trouve en Amérique du Nord, en Europe occidentale, en Australie, Nouvelle-Zélande. C'est là où la plupart des infections, jusqu'à maintenant, touchent les homosexuels et bisexuels masculins et les toxicomanes.
So you see, that was in 1900 and 1987, 7 years after the beginning of the pandemic. And he was organizing with us a conference in Paris, on the rights of patients who were AIDS or HIV positive. There were 10 imperatives to protect them as human beings. And it was incredible because everything was already discovered. And one of the worst stigmatized people were drug users. He knew that, and that's why we began in France, in Doctors of the World, to tackle this problem. There were hundreds of young people in the Bois de Boulogne. I don't know if you know Paris, but it was in the Bois de Boulogne. They were in such a terrible state. 50% of them were HIV positive. There was no contact with the hospitals. They had no possibility of taking care, even if there were no drugs disposable, but they were just hiding. And that's when we started to implement harm reduction. And this is the question I ask: what could the number of deaths of opioid crisis in the USA and in France? And I think, but we will discuss this, it's harm reduction. So you see, the other person I want to pay a tribute is Albina Dubois-Rouvray, is the lady who created this fund for the Center for Health and Human Rights at Harvard University and School of Public Health. Stigma is highly critical since it prevents patients from having access to treatment. The French model, after organizing this session on the rights of patients and HIV-positive patients, was to try to use the humanitarian model to put pressure on politicians to change the law and transform repression into care. We tried to fight against stigma very early on. These patients, drug users, and particular intravenous drug users, were utterly stigmatized and denigrated, with a prevailing view that they were guilty and almost deserved it. This struggle proved to be very long. We began with low-threshold programs to contact drug users and help them have access to hospitals. At that time, there was no treatment for AIDS, and 50% of them were HIV positive. We then commenced what were illegal needle exchange programs or syringe exchange programs, providing buses to bring needles to drug users themselves. It was a very difficult time because the police would assault our trucks, and break all the needles. They thought it was an harm reduction action. It took a long time to convince them. They changed. In the meantime, we continue our political pressure. We had a positive response from the Ministry of Health, but always the Ministry of Interior had a very strong position against our approaches. In 1992, Bernard Kouchner became Minister of Health, and it was for us a good tie to transform harm reduction and try to implement needle exchange programs, low thresholds, and opioid treatment. In France, there were no opioid treatments whatsoever. You see, if we start here in 94, 95, no opioid treatment. Then, very quickly, methadone, and especially the French model, buprenorphine, and we have today about 160,000 people under both methadone, Suboxone, and buprenorphine. What is exceptional is all these treatments are totally free, and you can get into a clinic to get them without any difficulty. So what do we see? We see that the number of overdose deaths are naturally very important in the States. This is NIDA figures. And here you have the number 450 in 94, and then a tremendous, it becomes very low, and then it comes up again a little bit. But we are still, you see 373, which is, we would have about 40,000 dead in France if it was comparatively to the population the same way. So there is such a difference. But why? Why is there such a difference? That's what I'm going, and oh yes, I wanted to show you also, you see, the AIDS epidemic. Here you have the AIDS epidemic, and at the higher, the number of dead from AIDS was very different from this one. So can we imagine an epidemic which is so important, and we should have an incredible strength against it? There was a very nice comment on the fact that for AIDS, they were organization, patients' organizations, AIDS, ACT UP, etc. It was militants, and they made pressure, and they got things. Maybe it doesn't happen in the States, but in France, these organizations had drug users in their staff and in their boards. So that means there was a continuous look on what was happening, and it might be one of the reasons. What could have been determinant? That's what I'm going to try to see, because our objectives were to increase acceptance levels regarding drug users within the general population, change laws and health policies, and act with drug users, not for them. With is the most important term, as it was said this morning. As I was visiting Harvard last year for the annual meeting of the FXB board, I met with Mary Bassett and Michelle Williams and expressed my concern about this situation. I later visited the BMC facilities for drug users with two friends of mine, by John Santiago and Ed Bernstein. And what did I find? I was horrified. In front of the hospital, there were hundreds of people shooting themselves. So I said, well, what's the problem? Well, these are very wise people. They choose a safe place. Apparently, they were pushed away after. It's maybe not the best medical attitude, but this is a complex humanitarian problem. I don't want to give lessons, I'm just looking at the facts. Severe drug dependence, injustice, economic inequities, and a lack of protection of basic human rights, the exact model Jonathan Mann would have tackled. Such a tragic situation obliges us to find ways to help these people, and particularly women and children. When I was there, in front of BMC, there were shelters. The men's shelters were full, but the women's shelter was empty because they didn't want to go there because they were afraid that their children might be taken away from them. So you see, it's a very sensitive human rights problem. Alors, what can we see? Pharmaceutical companies advertising in France, it's totally forbidden forever. No publicity in the general press. and no publicity saying there is no dependency in the medical press. The second point is painkillers. In France, we were very, very reluctant to give opioids. Morphine in a medical department, very difficult. When I went to make my practice in the States and I was on duty, I had morphine in my, because of cardiac problems, you know, you give morphine. It was easy. In France, it was very complicated. Patients had to suffer. You know, it's the Judeo-Christian attitude. Just suffer. But we thought it wasn't good, and we changed this, and the laws changed it. And now there is a very strong movement to give opioids to people who need them, especially chronic pains or cancer. But it's very complicated to get it. The prescription is complicated, and there is a big control on doctors, and the patients have to be trained to know how they can use those drugs. Opioid substitution treatment. Buprenorphine and methadone have been prescribed for a large number of patients since 1985, and general practitioners are able to prescribe. They can prescribe. So that's a big change. And everything is free. Everything is free. People say it's not fair. How can those drug users use all that public money? Everything is free. It's not only public money, it's also people who pay themselves. Creation of centers, very, very big centers, are created all over the territory, and it's a very easy access for the drug users. They are medical attended treatments, and counseling are provided on a large scale. Drug consumption rooms, that's very complicated. There's still a very strong debate about those rooms for the not in my backyard problem and for political reasons. 2 centers are now active and effective, and we see the difference. And now the self-user, self-help NGOs, these are essential since they have helped us engage and inform and give appropriate responses to users. Naloxone, we took a long time to have the authorization to take naloxone. I'm going to conclude. What is the future for us? Not to become like the States. In Europe, the figures are a little bit the same, except for Scotland. Scotland has a very high level, nearly like the States. That's also a question we should raise. I would like to use the model of the drug policy for Global Commission on Drug Policy and the criminalization, marginalization, and stigmatization of people who use drugs but who do not harm to others. Challenge rather than reinforce common misconceptions about drug markets, drug use, and drug dependency. The global war on drugs has failed with devastating consequences for individuals and societies around the world. It is possible that such intricacy against drug users are also responsible to the opioid epidemic itself. Misuse of and addiction to opioids, including painkillers, heroin, and synthetic opioids such as fentanyl, is a major national crisis that affects public health as well as social and economic welfare. It is interesting to see there are researchers which show there could be a relation between states in the US which have legalized cannabis and the number of opioid overdoses. There is a work in an economical journal, but I think people are starting a debate on this, and that would mean that these states are more active in the treatment of human rights. To end, I would like to tell you we should begin the transformation of the global drug prohibition regime, replace drug policies and strategies driven by ideology and political conveniences with fiscally responsible policies and strategy grounded in science, health, security, and human rights, and adopt appropriate criteria for their evaluation. Thank you very much.
Thank you. Thank you, Dr. Aeberhard. And now it's my great pleasure to present to you somebody who really probably needs no introduction since most of our audience is from Massachusetts, Dr. Monica Bharel, who is the Massachusetts State Health Commissioner, and I believe today our first representative of government. So now, please, come join us, Dr. Burrell. Your full bio is in under Dr. Bharel's leadership, fatal overdoses have declined. Thank you.
Thank you, Dr. Bassett, Dean Williams, Dr. Koh, all of you esteemed guests. I went around as if it was a homecoming, so many people from the front line of tackling this opiate epidemic and for making sure that individuals among us have opportunities for health, no matter what their background here in Massachusetts. To our colleagues visiting us from Michigan, welcome to Massachusetts. We are thrilled that you are here. As we learned from just hearing about what's happening in France, there's lots that we can learn from each other. So we're so happy to be sharing best practices and lessons learned. You know, what was the quote, Patrick, that you have, that France is trying not to be like the United States? So maybe the United States needs to try and be more like France. But, you know, you could get pessimistic seeing those numbers and looking at ours, but what it tells me is since we know that us humans, no matter where we live, are more alike than we are different, then policies and programs that we put in place can make a difference, and so there's lots to learn from each other. So let me take you on a whirlwind tour of what we've been doing here in Massachusetts, and I'm going to do it through the lens of data. I'll start by saying that for me, this is a very personally important issue. I spent 20 years as a frontline physician caring for individuals suffering from substance use disorder, and I saw firsthand how challenging it was to get the care that they needed. And today I believe, as I did then, that the most important thing for us to work on is the issue of stigma. So I'm so glad that we're taking this on. So as you look at the narrative and the individual stories, we then pair that with data, because again, another line I'll borrow from the speaker before me is, I'm not here to lecture you, I'm here to show you the data and you can make your own conclusions. I want to frame for you the Department of Public Health House. This is a model that we put in place in 2015, and it helps you to understand why we look at data the way we do now. At the Department of Public Health, I'm humbled and honored to say that our mission is to protect and promote the health of all individuals across Massachusetts. And what we've been doing since 2015 is using a strategic framework that includes using the data that we already have, looking at the social determinants of health that impact all of us, and then putting a laser focus on where our data disparities are, and unearthing the health inequities related to that, and putting our limited resources specifically in those areas and looking for outcomes. And we do that, our best case study of that is our work with the opioids, although we're using it throughout the program. So think about this as you hear me talk about this. First, our opioid data. Those of you in Massachusetts, I hope know that we put out quarterly opioid reports that look at the deaths that we're facing and we're seeing and try to understand those deaths so that we can go upstream from that and understand where people are dying, how they're dying, who's dying, and how we could intervene for individuals. We used to put those out with a 2-year lag, and now those are quarterly reports. Let me share some of the highlights with you. When you look here, you'll notice a couple of things. You'll notice the steep increase in the number of opioid-related overdose deaths. When you look at that last area from 2013 up through 2016, we did not see that kind of acceleration in deaths from any single disease entity here in Massachusetts since the beginning of the HIV epidemic. So this is a call to action for all of us. Next point, at the end in 2017 and 2018, you'll see red areas at the top of the graphs. That's using our predictive modeling techniques that we developed at the department to be able to produce these reports in a more timely manner using more advanced analytics. Last point I'll make is you'll see that thankfully, in the last few years, we're one of the few states to be seeing a slight decline in these deaths. It's a steadying of this disease. Of course, there's more work to do. There's 2,000 people dying of preventable disease every year in Massachusetts, but we know that our interventions are making progress. The green arrow moved a little, but what I want to show you again is emphasizing 2013 to 2014, a 40% rise. So when we look at this 4% decrease, and you may say, well, is that really something notable? Remember that we were on this 40% rise trajectory, and so we're seeing a slowing of those deaths. What this shows you is the presence and the impact of fentanyl. If you're at the front line, I don't need to tell you this. I mean, fentanyl was a game changer in terms of opioid overdose deaths. So this is looking at the autopsy reports, so the toxicologies that were done in those individuals who came for autopsy. And you'll see that now almost all of the individuals have fentanyl present at the time of death. You'll see that important point, the blue and the red line, at the end of 2015, where it crosses over, and we started to see a decline in heroin and an increase in fentanyl, more powerful, more deadly. The other thing I want to point out here is, if you look at 2019, it's still a polysubstance disease. There's still cocaine, there's still benzodiazepines, and there's stimulants. You can't appreciate it here, the orange line on the bottom, that are rising again. People who work on the front line know that a lot of patients are talking about meth again. This is our prescription monitoring program data. What I want to talk to you about here is to show you, if you look at the blue line, that's Schedule II opioids in our communities in Massachusetts. If you look at the green line, that's use of our prescription monitoring program, the database that clinicians, prescribers could use to see what medications their patients are on. And when you look at the time that we put in a new and improved PMP system, and when it became mandated to use it every time an opioid was prescribed, and now also a benzo, you'll see that as that green line, as that happened, the use went up, millions and millions per quarter, and the Schedule II opioids went down by about 40%. Here's another thing that we put out in our last report 2 reports ago. We're talking about best practices here to us. It was very interesting to us as we put out statewide policies that within communities there is variance. So we shared these with our colleagues. Any place we saw a 10% improvement in the death rates, that's the green, or a 10% worsening of the death rates. And again, we put this out publicly, not meant to criticize anyone or even to applaud one community over another, but for individual communities to be able to talk to each other and say, what are you doing that's working? What are you doing that's not working? And it has happened with these communities, and there's been interesting findings. Because whatever we do at the state level, at the country level, it's really at the community level where the real change happens and the investment happens across the community. We've stratified our data in many different ways as we've begun to look at it since 2015, and this is one example that was striking to me, so I'm sharing it with you. When we looked at the data from 2014 and 2017, I showed you that death data. We decided for the first time to break it down by race and ethnicity. And as we started seeing our decreases in rates, you can see the all, it's down for all, that's a good thing. Look at the white non-Hispanic, it's down for all, that's a good thing. And look at the Hispanic, we had a rapid increase, but then started to come down. And the only group that we found that was still having a rise in the increase, or in an increase in opioid deaths, was our Black non-Hispanic community members. And when we broke this down by male, female, we found that it was actually male, Black, non-Hispanics who were having, the only group in Massachusetts still having an increase. And this was really powerful information for us, which we then used to concentrate resources in communities of color. So I raise this for you because the way that we're looking at data and breaking it down here in Massachusetts is helping us understand where to target our work, because it's giving us information that we never had before. And maybe if you just look at a population level, you may not have been able to pick up on this. I also want to talk about naloxone. I think it's been a real success here in Massachusetts. This is what's called the Bystander Program, so some people call it the Friends and Family Program. It's a program we run out of the Department of Public Health, where anyone who's interested in being trained, any layperson who's interested in being trained on how to use naloxone, often known as Narcan, can be trained, and we track how much that Narcan is being used. You'll see here that, interestingly, most individuals who are users are using it among other users, so right, infiltrating a community and having them have access to it, but you'll also see that the rate of use has really gone up. This is one part of our naloxone program here in Massachusetts. The other is making sure that pharmacies have capacity with a Massachusetts-wide standing order, and providers are educated in prescribing it. And then lastly, that EMS. So we're also one of the places that was the first to have EMS, first responders have access to Narcan so they can bring it to the scene. And I feel this has been a real contributor in us stabilizing the deaths and can contribute to further decreases. If you look at modeling studies, our own Dr. Wally from BMC did one of these mathematical modelings. You can see that when naloxone is fully penetrating a community, you see an almost 50% decrease in opioid overdose deaths. So when you pause at that, we're here talking about stigma today. We know what works. We have data-driven solutions of what works. It's about finding ways to implement those and get them in the hands of the people who need them most. I'm going to talk just for the last few minutes about some advanced data analytics we're doing. I'd like our friends in Michigan to know about this, and I'm really excited. I want to make sure everybody in Massachusetts knows about this. So I talked about data and bringing data together. So in Massachusetts, for those of you outside of government, we had to change the state law in order to bring data together, including data that was all within the Department of Public Health, in order to better understand this epidemic. So what you see here is the different buckets of data, or silos of data, if you will. The gray ones are the ones within Department of Public Health. So when I came to the Department of Public Health and said, oh, easy, we should look at the death data and put it together with the prescription monitoring and what addiction services, and find out where the patients are going and where the gaps are. It wasn't legally possible. So we changed the laws in order to, at an individual level, for the first time in Massachusetts, securely link this data temporarily and answer questions that many of us have had for a long time about how to treat addiction, and in this case specifically, opioid addiction. And I'd like to say that we're using this model throughout the Department of Public Health now to answer really challenging public health questions. So I'm happy that we have been able to have the opioid epidemic allow us to have this tool. So let me just give you a flavor of some of the things and how they've helped us. First, opioid use disorder prevalence. Opioid use disorder prevalence in Massachusetts is about 4.4%. So what? How do you treat a problem if you don't even know how many people have it? That, by the way, is about double what the previous estimates were. So really understanding step one, what are we dealing with? How many people are affected? What resources do you need to care for them? Next, this is the survival curve. If you go to the end and work yourself back, it's individuals who died from an opioid epidemic. This, by the way, this Chapter 55 data, importantly, is 2011 to 2015. So before any of these interventions I told you about, we're working on renewing the data. So if you start when people died and you go backwards, upstream, their first use of a prescription opiate from that time to death was 36 months. That's horrifying. If you think about survival curves we look at in other diseases, this helped me greatly in talking to my legislative partners and others who go through cycles of making laws and other things that oftentimes can take years to say there is no time to wait, we have to act now. And this was incredibly helpful in that. Looking at medications, this has been alluded to before. Again, talking about what we know works. Everybody here in Massachusetts, I'm a medical doctor, so I can say it, this is the best place to practice medicine, and we're really good here. So what this shows us is that if an individual with a non-fatal overdose prevents for clinical care and receives buprenorphine or methadone, their chance of then dying from a fatal overdose goes down 50%. Think about a chemotherapy that did that for a patient of yours and how quickly we'd all be on board on that. In Massachusetts, again, this is 2011, 2015 data, at the time, only about 5% of individuals were getting that care that they needed. So again, what's in the way? Sure, it's awareness, it's education, it's access, it's making the meds easily available. It's also stigma. This has helped me a lot with my clinical colleagues in terms of what can we do, what can I do? Then we wanted to understand who are the highest risk among us. Who are the individuals who we may not be reaching or caring for who are at highest risk of dying? And I'll show you a couple of those groups to end. Number one, individuals with a history of incarceration. We found that any history of incarceration, 120 times greater chance of dying from an opioid overdose. This fact and the facts behind it alone opened the doors for us to speak to our colleagues in criminal justice in ways that we had never been able to before. And maybe many of you know that for the first time in Massachusetts, we're providing medication for opioid use disorder in our criminal justice systems, in our prisons and jails. And this really helped us in the arguments that we made for this. Another high-risk group near and dear to my heart is those who have had a history of housing instability or homelessness, 30 times increased rate of overdoses, and this and the facts behind this have really helped us think about when we enhance individuals' opportunities for recovery, what does that mean, and what does that mean related to their housing stability and the other social determinants of health, as I mentioned earlier. Another group is individuals with serious mental illness. I'll point you to the two areas in orange. If you look at individuals who have serious mental illness, schizophrenia, psychosis, others, they have a profoundly higher rate of overdose. And even bread and butter depression has an increased rate of overdose. So when we look at our work and how we work with our colleagues at the Department of Mental Health, how we're cross-trained in substance use disorder treatment and mental health treatment, we're really working at the state level to integrate that, and have done several projects with our colleagues throughout Mass Health, Department of Mental Health, to work on that together. And the last high-risk group is pregnant and postpartum women. If you look at a woman's risk, the first line is her baseline risk of an overdose. And then you go through her pregnancy, you see the risks go down. Unfortunately, you see after the birth, it increases. And what really was important for many of us to see was that her highest risk of death was 6 months to 12 months after birth. And if you looked at the programs that we had put in place, well-intentional, good meaning programs, not many of them went out following a woman for a year after. So this really gave us an opportunity to look at, again, these are resources we're already putting in the community, but can we do it better and smarter because of the data that we're seeing? The governor has an action plan that's been in place since 2015. What's most important to me about this action plan and what makes it successful is it's multi-sectoral. I touched on that a little bit, but it really goes across. It's not just public health. It's not just healthcare. It's not just criminal justice. It's all of us together. And the other thing is that it's looking through this problem through a public health lens. I didn't get much to talk about prevention today, but primary prevention is a core part of what we're doing at the department, as well as intervening for individuals who need access to things like naloxone and navigating to treatment, expanding treatment and supporting people in recovery. And to me, that's been the greatest success of our program. Ending again on the people. So it's important to raise the voice of those who are suffering from this disease. We have multiple ways we do that. I just put your eye to this new campaign, My Path, My Recovery. We often use actors in ads. These particular ads have real-life individuals who are sharing their stories, explaining how they found opportunities for recovery. Because people don't see hope in this disease. They look at the numbers, they look at the death, and this is an opportunity for them to understand there are other ways. Lastly, we're relaunching our State Without Stigma campaign that we initially launched back in 2015, so we're relaunching that. This is the Red Sox Foundation, Jackie Bradley Jr. and his wife, Erin, graciously offering their time to talk about this. The more we talk about this, the more we get famous people to say that it's okay, this is a disease, and there's opportunities for treatment and recovery, the better it will be for all of us. I'm over time, sorry, Mary, and I'm thrilled to be here with all of you, and thank you so much.
I want to thank Dr. Burrell in a masterclass in public health and in implementation. I'm in absolute awe. You know, I'm from New York City, and we think we can go toe-to-toe with Massachusetts, a whole state, but not on data. And this is the most incredible collection of data that I've ever seen. So congratulations on the whole program. Congratulations to all of you for being such a good audience. We've heard about stigma in people's lives, in our historical record, in the way in which clinicians experience their practice. And now I'd like you to take a break for lunch. We don't have the mayor of Somerville here, so he's given you back 15 minutes. Please be back at 1 o'clock sharp. Thanks very much.